This is Alan Heckman from the DeSales University Physician Assistant Program, and today I'm going to be talking about complex regional pain syndrome. Complex regional pain syndrome is a disorder of certain body regions. Typically, it's of the extremities, and it is characterized by pain, swelling, limited range of motion, vasomotor instability, skin changes, and patchy bone demineralization. This typically follows some type of an inciting event, such as an injury, which is pretty common, surgery, or a vascular event such as a stroke. They typically have this event first, and then will develop these symptoms later on that constitute this syndrome of regional pain. If you review the literature, this is not a new condition. It's been around for quite a while, and different segments of it and different parts of it have their own eponyms or specific names associated with it. Previously, complex regional pain syndrome was more commonly referred to as reflex sympathetic dystrophy. However, that term is sort of changed and is not used as often anymore, and more people are using this complex regional pain syndrome as the actual terminology. Incidentally, if you have upper extremity involvement, another eponym that you can see here at the bottom is just shoulder-hand syndrome. So any one of these terms, if you're hearing this, you should be thinking complex regional pain syndrome. A diagnosis of this syndrome requires the presence of regional pain and sensory changes following some type of a noxious event. So there needs to be an event such as an injury or a vascular event like we mentioned earlier, and then following that you're going to have symptoms of regionalized pain accompanied with sensory changes. The pain associated with this condition is generally greater than that would be expected of the inciting injury itself. And then typically this is associated with an abnormal skin finding, such as a change in color or temperature, and an abnormal pseudomotor activity or edema. Now, pseudomotor activity is referring to sympathetic stimulation of sweat glands, and in this particular instance, they're being stimulated abnormally. Complex regional pain syndrome is divided into two types or two categories. The type 1 corresponds to patients who have the syndrome without a definable nerve lesion. And this is most of the population. About 90% of patients with this syndrome have type 1. Type 2 is folks with regional pain syndrome with a definable nerve lesion. The pathophysiology of this syndrome is unclear, and the theories that are out there can be rather complex. So hopefully I broke it down here for you in some easy, understandable concepts. All right? Here's what we generally know or what we hypothesize about the condition. That there appears to be involvement of the formation of a reflex arc after the inciting event, whether it was an injury or a vascular event. All right? The arc then follows the route of the sympathetic nervous system, which is modulated by the cortical centers, and it produces a peripheral vascular disturbance. The pain sensation in response to the injury may lead to increased sensitivity of the injured axons to the neurotransmitter epinephrine and other substances released by local sympathetic nerves. Now that's a little confusing, but we're going to clear it up here for you in just a second. Now, going back to what I mentioned earlier here, typically this follows an inciting event. Now, some studies were done on this, and they found that soft tissue injuries were present in about 40% of the cases of complex regional pain syndrome as the inciting event, fractures in 25%, myocardial infarctions in 12% of the patients, and a stroke in about 3%. Other studies in my research show that 35% of patients with complex regional pain syndrome had no precipitating event. Other data I found showed about 5 to 20% of patients had MIs, and about 12 to 20 had some type of hemiplegia, probably secondary to a stroke. Arthroscopic procedures was the most common precipitating event in 60% of patients with chronic pain syndrome of the knee. Placement of an AV graft for hemodialysis was associated with it. The administration of cyclosporin, and emotional stress can be an important precipitating factor, and that's an important point to remember when we talk about treatment later on. All right, so what happens here? You have an injury that occurs. Let's say you stub your toe or you get it caught in a door. From there, you get pain signals which travel to the central nervous system via peripheral nerves, right, the afferent sensory nerve. Once it's in the CNS, pain is perceived and a reflex arc is established, and it immediately sends a signal back towards the injured area via the sympathetic nerve pathway. The injured area is then stimulated by the sympathetic innervation, which causes vasospasms and release of inflammatory mediators. This reaction produces new pain in the area that once again travels to the CNS through the afferent nerves and basically starts the process all over again. It travels back up through the afferent nerve where it's interpreted, it hits the reflex arc, and you get increased sympathetic stimulation, and this just keeps going on and on and on. I found this diagram here which hopefully illustrates this point a little bit clearer for you. So you start off with having some type of an injury, and we'll say here it happens in the wrist. And from there, you have the pain that travels through the afferent nerve fibers where it's interpreted in the brain. Here, this reflex arc is created. So from there, you have sympathetic stimulation that travels down back to the area again where you had the injury. And from there, you're going to get a release of inflammatory mediators as well as some vasospasm activity secondary to the sympathetic innervation. This sympathetic innervation here and the release of the inflammatory mediators actually causes increased pain, and it triggers other responses there of pain. And from there, it comes right back through here and travels right back up again where it keeps coming down. So you can see by demonstrating these arrows down here, it's a constant cycle of pain going back up to the CNS and coming back down, and this goes on and on and on. There's some limited data out there right now that suggests there may be a genetic factor associated with complex regional pain syndrome. A study was done here with 15 women attending a pain clinic who ended up being diagnosed with complex regional pain syndrome that seemed to have some type of human leukocyte antigen. And what they found that there was like a twofold increase in this antigen. What was interesting in their study is that they found resistance to treatment was noted in 5 of the 6 patients who were positive for having this antigen, suggesting that there may be a possible genetic factor associated with some patients with poor treatment outcomes. Complex regional pain syndrome, from a clinical point of view, is broken down into 3 stages. Each stage correlates with the severity of the disease, meaning that stage 1 is not as severe, and all the way to stage 3, which is the most severe form. Stage 1 typically follows the inciting event and is described as a burning or throbbing pain, an uncomfortable aching, sensitivity to touch or cold. That's important. A lot of these folks develop a hyperesthesia, and so they become extremely sensitive to any type of pressure or touch sensation in the affected area. Also, localized edema is also appreciated. The distribution of pain is not specific to a single peripheral nerve. You can have vasomotor disturbances, which produce altered color and temperature of the skin, giving it what's known as a mottled look to it. You'll see some areas that are pale, some areas that appear to be more flushed. Radiographic evidence at this stage is generally not helpful, although you can see some patchy demineralization of bone. Stage 2 of the syndrome is associated with progression of soft tissue edema, thickening of the skin, muscle wasting. Why? Because these folks tend to have some immobility and are not using the limb or the joints around there. So if you're not using the joint or the muscles, you'll get atrophy of that muscle tissue. And then development of brawny skin. This may last for 3 to 6 months. The third stage of the syndrome is by far the most severe, characterized by a severe limitation of movement. In fact, folks here with the shoulder-hand syndrome can actually get a frozen shoulder as a result of this. You get contractures of the digits, you get a significant waxy skin changes, brittled nails, and at this point, radiography of the bones will definitely show a severe demineralization. It's important to know that the longer you stay in stage 3, the more difficult it is to try and bring you out of it and treat the condition. This is why identifying this syndrome as early as possible is important to begin the treatment to hopefully halt the process or keep it from going to this stage if at all possible. Autonomic dysfunction is seen with this syndrome because it involves the autonomic nervous system. So some of the features that you can see in the later stages of the process would be things like cyanosis, modeling of the skin, like I mentioned earlier, although it can be seen in earlier disease, increased sweating, as I mentioned in the first couple of slides, abnormal hair growth, diffuse swelling in non-articular tissues, and coldness. Diagnosis of complex regional pain syndrome is made clinically, although this can be difficult to do in the early stages of the disease. It may actually look like another condition, such as cellulitis or septic arthritis. You need to pay attention to what the patient's telling you by describing the pain as a throbbing, burning pain, paresthesias, and altered skin temperatures. These things might be clues that might help key you in to think this could be complex regional pain syndrome. And another important factor here would be getting a good history to see if there's been a previous inciting incident to that area, like an injury. Autonomic testing and scintigraphy may provide some type of clues to the diagnosis, although these are typically done later in the course of the disease. Response to treatment is an excellent diagnostic tool. If you suspect that patient does have complex regional pain syndrome, put them on appropriate therapy for it and watch them get better. That helps to solidify that you made the correct diagnosis. Autonomic testing is available to help provide some type of objective data regarding the diagnosis of complex regional pain syndrome. Like I mentioned before, this diagnosis is made clinically, but there might be some circumstances in which you might need to do further testing, such as if the diagnosis is unclear or if there's some type of medical legal situation in which objective data is being required. The testing consists generally of a resting sweat output, resting skin temperature, and a quantitative pseudomotor axon reflex test. In my research, I found that there were some studies in which patients that had an abnormal pseudomotor axon reflex test, if they had an increase in their RSO, this was predictive of a diagnosis of complex regional pain syndrome. Most people, though, tend to just measure skin temperature and look for sensory changes. These are certainly less costly and more commonly used, but they're not as sensitive as the actual true autonomic testing, but it is something to consider when you're doing your workup on these patients. Imaging studies are available to help aid you in the diagnosis. Bone scintigraphy is a nuclear test in which a patient presents while actively having symptoms. A radioisotope is injected and they're able to see a slow uptake in the bone, which demonstrates typically a decrease in perfusion to that area. Plain radiographic films can be obtained. This typically shows osteopenia or bone demineralization. However, it can sometimes show actual destruction of the joints and adjacent tissue. MRI can be a useful tool, particularly in helping to determine which stage of the disease or condition the patient is experiencing. In addition, CAT scanning is also potentially helpful. It does show you areas of bone demineralization. You can actually see areas of osteoporosis which appear like a Swiss cheese-like appearance, which is typically seen in stage 3 of the condition. A response to therapy is generally considered to be a very helpful diagnostic tool, when determining if your patient has complex regional pain syndrome. Typically, a regional sympathetic nerve block or some type of anesthesia is applied to the affected area. This tends to be transient, but if the patient does have a positive response following that, such as a reduction in pain or changes in the altered sensation, this helps to point towards a positive diagnosis of complex regional pain syndrome. There are multiple differential diagnoses to consider when you're suspecting a patient has complex regional pain syndrome. Typically, early in the disease, it can present with similar findings that would suggest possibly avasculitis, an AV fistula, angioedema, but some other process here other than complex regional pain syndrome. You need to take some of these factors into consideration here so that you're not missing another diagnosis. Treatment. Patient education is extremely important here. These folks need to basically understand what condition they have and a little bit of the pathophysiology, at least from what we theorize or understand about it. What they've found is that if the patient understands their condition, you get better buy-in from them with regards to things like occupational and physical therapy. In addition, psychological assessment and counseling is very important. Some of these folks, because it tends to be a chronic pain syndrome, will end up developing things like depression. In addition, having some psychiatric illnesses may increase your comorbidity with this syndrome. So having a counselor on board is going to become very important. It's recommended that you get consultation with a clinical psychologist if the patient has complex regional pain syndrome for greater than 2 months in duration, if there's no response to treatment, and if you suspect a comorbid psychiatric disorder. There's mixed data available right now on whether physical or occupational therapy is beneficial in these patients. There was some studies that showed there was improvement when compared to a control group. However, there was no difference in range of motion noted after 1 year of therapy. They did report there was some less pain, but no change in the range of motion. Smoking cessation is important. They have found that smoking appears to be an independent risk factor for this syndrome. A retrospective study of 53 patients with the syndrome found that there was a higher incidence of smoking in patients with complex regional pain syndrome when compared to controls. There are medications that can help with this syndrome and have been proven to be helpful in clinical trials. Anticonvulsants have been shown to be helpful with patients complaining of complex or persistent pain syndromes. Bisphosphonates to help with the osteopenia, as well as steroids and nasal calcitonin. Antidepressants have not been clinically studied with patients having complex regional pain syndrome, although experts in the area have found that using antidepressants may actually be beneficial in these patients. They have found in the past that antidepressants have been used to control or help manage folks with pain syndromes, and so therefore it makes sense that it would potentially help these patients here. So right now, there's been a consensus of experts that suggest beginning a patient with complex regional pain syndrome with some type of a tricyclic antidepressant to see if that helps manage their pain. Sympathetic blockers have been used in the management of complex regional pain syndrome. However, there were 12 trials or studies that showed no statistical benefit when compared to controls. However, people who are managing these patients still tend to use them in their clinical practice. Agents like propranolol and clonidine have been used with anecdotal data suggesting these are helpful. Expert report of a trial of a sympathetic blocker added with an anticonvulsant or an antidepressant has been shown to be beneficial. This is coming from experts who treat these patients. However, no clinical trials have backed this anecdotal data thus far. Patients with complex regional pain syndrome should be followed regularly. If you're treating them in stage 1 of the disease, they should be seen on a weekly basis. And your goal with therapy should be a decrease in pain, improved mobility, and a better function. If your patients, after a few weeks of some type of oral therapy and physical therapy, are not showing evidence of improvement, then they could be considered for some type of invasive form of treatment. Patients in stage 2 and stage 3 of the disease are also candidates for invasive therapy if they're not improving on the existing therapy that you've set up for them. Invasive therapies can include trigger point injections with either a steroid or a local anesthesia, nerve stimulation, or epidural injections of clonidine. However, while this has been shown to be helpful, you do have to worry about the side effects such as hypotension and sedation occurring from this medication. Regional sympathetic nerve blocks can be performed with either a local anesthetic or some type of an intravenous infusion. This tends to be limited though and only gives you temporary relief. Spinal cord stimulation is also an option. It can be helpful in patients who have failed other treatments up to this point, and it tends to benefit patients more who have this syndrome limited to one extremity. Then there's a sympathectomy, which is either a chemical or surgical process, and basically what they do is they go in there and they will inhibit the sympathetic ganglion going to that affected area. You have to understand that this procedure is permanent. Once you go in there and you disrupt the sympathetic ganglion, it is not going to regenerate at this point. The prognosis for patients with type 1 complex regional pain syndrome, if you remember, that is the syndrome in which no identifiable nerve lesion is noted, tends to be pretty favorable. About 74% of patients report resolution of symptoms, some of them spontaneously without any specific therapy. Recurrence of the syndrome, though, is not uncommon. About 30 or anywhere from 10 to 30% of patients have a chronic recurrence of the complex regional pain syndrome, particularly occurring in younger patients, including children. All right, folks, I hope I gave you a little bit of information here on complex regional pain syndrome. This was not meant to be an all-inclusive presentation, but just to give you a little bit of background information regarding the disease, its pathophysiology, and treatment strategies for it. As always, if you have questions or issues, feel free to email me or come see me. Thank you very much for your time and hope you have a great day. Thanks.